Indeed. So I want to get right down to it, but I'll open the floor to any comments or questions. And, our shared experience is really part of what this is about, understanding what stretches us as Bowen therapists or as therapists doing other things as well that relate to Bowen therapy. And yeah, if you can, um, just give me your thoughts and comments. It would be great.
Do we just chime in?
Yes, please do.
Oh,
Please do.
okay.
I'm just
I thought there was
all
more
ears.
formal, like raise your hand, be recognized.
Oh no,
Uh,
just chime in. We're so few people.
Giuseppe, you have the floor, that sort of thing. So,
Okay.
uh, um, you had asked me when we had our individual Zoom
Yeah.
about how you just wondered how I would fit the Bowen into a busy clinic like we have. And I we're just lucky that we have the amount of time to spend with one person at a time. We don't do several people at once, like a lot of physical therapy clinics do. And we're not exclusively a physical therapy clinic, it's a chronic pain management clinic. And we try to provide unique therapies for persons who are experiencing chronic pain. And, uh, and the Bowen therapy has been a marvelous addition to our armamentarium of many other strategies to help persons with chronic pain. I am thoroughly impressed with how the Bowen can be used uh, as not an adjunct sounds a little dismissive, but I would say actually a part of the fabric of care in our facility. The first insight that I had with it was uh, how it was able to stimulate people's parasympathetic responses, and that is a very blatant, important need for many persons with a chronic pain um, condition. Our department also provides breastfeeding support from the physical therapy staff. And the Bowen has also been a wonderful addition to the fabric of what we can provide to moms and babies. We don't exclusively use the Bowen. We don't exclusively use the Bowen for anything. It's always used alongside of other strategies. Uh, uh, Trying to, in some ways, it's consistent with a holistic look at a person and what they need. Uh, um, as is the premise of the Bowen technique anyway. So um, I'm thoroughly impressed with the times that it is very helpful. I feel fortunate since I've only been practicing this for this year that I have been able to help people the way I have using the Bowen techniques. I am I just want to get this off my shoulders here. I have done a lot of reading research and video research in that time that I've been doing this. And Jonathan, I just cannot express the depth of gratitude of the effort it took you to put together the text that you put together. It has been absolutely invaluable, and I wish you would know all of the people that you have touched through that, even in my practice, let alone the practice of our other physical therapists. Um, I'm sorry if I got off the track there with that monologue, but
Great.
I really want to express our appreciation for not just you, but also all the people who are in the circle of providing Bowen in the many ways that it's done.
Well, it's really wonderful to hear you say that. That's very gratifying. And touches on the subject I wanted to raise tonight. We always read and are taught how less is more. And there are times when that's absolutely true, when it comes to any therapy, and perhaps especially Bowen, because of that connection to the parasympathetic that we want our patients to experience and revel in. We get them into that state and we want their body to do the work. However, there are going to be times when we do too little. And I guess my first question is, who feels they've done too much on a patient of Bowen therapy? If anyone has had that experience of doing too much.
Well, I can tell you I have.
Yeah,
Uh,
yeah. What did
uh,
you, what was the result?
the results were adverse reactions that I wasn't expecting, but
Mm,
the um, uh, the the experience is not foreign to me because of the clientele that I work with. And
mm,
so there is this invisible line of too much and too little, and it's different from person to person, and it may be different in the same person in any particular phase of their life. And I was again not intimidated by that because if something can provide an adverse reaction, it only tells me the physiologic significance of what it was that was done. Not necessarily that it was on target, but rather
mm.
that it should not be avoided. It should be examined and understood as to why that was the case at that time.
Yeah, yeah, yeah. Very good. Very good. Hmm. Hello, Valerie, is joining us. Hello, Valerie.
Hello, everyone.
Hello, how are you?
Good, good, good,
Yeah,
good. Hmm?
great, great.
No, it's
Well,
okay.
you, you are most welcome. Thank you for joining. And we were just talking about, my question was to everyone, who has experienced doing too much to their client, as most of us are, really overtaught to do as little as possible. And it's my experience both ways that yes, we can really easily aggravate a person. And I think that happens for one particular reason, their vitality, their ability to foster or the resource of their energy to heal. It takes a lot of energy, and we can only push as hard as they're able. And that's the person that has usually the big story, a big, long, complicated story of illness that's needing to be managed um, with a lot of care, either by themselves or by the many practitioners they might have. So that's usually my motto when I teach is the bigger the story, the less you do. And I think that's partly true, especially these first cases. However, what I am experimenting with now is when there's a gross pathology, such as in a hip joint disease, where I would want to see a bigger change in that pathology, such as a bigger um, correction of misalignment, a bigger reduction of inflammation. And I know that a lot of you have learned about the sort of sacred trio of Bowen therapy, which is pelvis, sacrum, and coccyx. We do this as a sort of trio combination, not always together, but in a sort of sequence of treatment. Very commonly, pelvis and sacrum, and then a following visits would be coccyx. And I've learned the hard way that if I take the misstep and try to treat coccyx first without freeing, in a sense, the pelvis and sacrum, I won't get as fast a result. I'll have to almost return to the pelvis and sacrum before the coccyx will release. So that's a very interesting subject. And I've now got a new trio that I'm using a lot. in the similar vein for hip joint disease, which we would often have just relied on pelvis for. And so I want to just refresh you. I'm going to share my screen and refresh about the pelvis and share screens, desktop. Okay, very good. I'll just share. Hopefully you can see most of my screen, and I've got a couple of procedures open. I had hoped to do get rid of that. So here you should see the pelvic procedure more or less fully. And we're going to, how do I move it forward? Oh, I'm sorry, I have to get the navigator to show. Yeah, I have to show this. So pelvic, we know for all those problems of the hip, the groin, the pelvis. We observe leg length discrepancies. There may be low back pains. We often see gynecological problems, and always knee, ankle, and foot problems are most certainly going to be associated with the knee. There is a very important assessment of the of a choice of procedures. So this is called the Faber test. It's where we bend, the client is on their back, we bend their knee and try to place their ankle just above their knee. So the opposite ankle, you bend that knee and place it opposite, and then you flex the hip joint, holding the ASIS, the hip bone, and flexing the knee towards the table. This can give you some very important indications. And one of those is the sacral procedure, when they experience tightness or discomfort in their back. When it's on the lateral border of the ilium or the trochanter, essentially the iliotibial tract, we would consider the coccyx procedure at a future. If they have discomfort on the lateral side of their upper thigh, where you have the muscle called tensor fasciae latae, we have a procedure called rectus femoris. So those we know. These are all very straightforward. And just bear in mind, we're freeing this muscle here, adductus longus, and the sartorius muscle, the vastus lateralis, and then the inguinal ligament here, while we do a flexing of the hip. So these are those muscles seen more visually. You can see how they all, or two of them, attach at the ASIS, and adductus longus, of course, is attached at the pubic bone here. And that's the inguinal ligament. So these, in the way they govern the hip joint, are very important, especially adductus longus. There is a muscle above this one here, the iliacus. This is the ASIS, your hip bone of the front, and iliacus is here. And there is a procedure called iliacus release, which I've now added to many of my hip treatments. It's fantastic at releasing the internal bowl of the pelvic floor. It's a really marvelous muscle to work on. You can see it here. It's in the sheath and the fascial sheath, and we're going in superiorly and trying to hook as much of the muscle as possible. You can actually do it to yourself, and I really recommend you try. It's if you go straight down with your third finger on the inside, on the medial side of the iliacus, and poke down and just feel around against the bone, and you'll feel muscle, a muscle edge, and that's what we're going to release when we do that procedure. I've got it showing somewhere. It's this one here. And this is quite interesting to see. Let me just put that there, like that. Oh, I can make that smaller. Just a moment, get that to be smaller. And so you can see this is on in the manual 5 and 6 on page 29. And let me just get rid of that. Whoops, too many buttons. Get rid of that. So there you can really see it. I can make it a bit bigger. One of the main indications is difficulty straightening the spine and the hips. Flexing the hip. This is an indication I don't really see a lot, where a low pot belly is seen. But inguinal hernias, that could be an indication. Groin pain, of course. And postpartum abdominal tension would be also something interesting. And you can see he previously recommended procedures. Coccyx pelvis, rectus femoris are all in that story. And then I'll just go to the next slide and show you what we're working on, this one. So you do it bilaterally. It's very wise to have the client bend their knees while they're lying on their back so that you've got easier access into that area. So 2 superior lateral moves. And of course, the slack is the opposite direction. So you want to be starting about there with your middle finger pointing inferiorly, pointing towards the feet. And you reach in, pushing aside the skin, getting as deep as possible onto this muscle edge. And it's quite uncomfortable if you get it correctly. And honestly, it releases very quickly and easily. So any thoughts or comments? Oops, I'm going to the wrong. I want to go to Zoom. There we go. Everyone's okay with that? And then my third, so pelvis, iliacus, and then the third is something interesting as well. It's on the posterior side, and it's a procedure we call deep sciatic. Just move that aside, get rid of the formatting button, and there we go, deep sciatic. So this is often a sciatica. The pain is deep in the center of the buttock. Really what we're talking about is piriformis syndrome, essentially. And this can be associated with hip joint disease and nothing more. So to release this area helps a person with hip joint issues. You know, I think that Bowen is a marvelous treatment for orthopedic problems. People who are grumbling about their hip joint long before needing surgery. And this could be part of a plan of action to treat that. This procedure, we're really targeting this muscle here, piriformis, and the sciatic nerve beneath it. And while I'll go to this picture here on the right, we palpate by simply pressing in to this midpoint of the buttock, bearing in mind that the gluteus medius, so midpoint from the lateral border of the gluteus medius here and the midline here. We want to palpate inferiorly and superiorly, down and then up, or up and then down, asking the client for the most tender point of pain. And when we have that, we do this little trick with raising the limb 4, 5, 6 inches, and then moving it laterally 20 or 30 degrees out. And what that does is it opens up a space for your thumb or finger to sink deeper. And you want to ensure you're still on the painful spot. And then it's just an activation, a gentle poke towards the front of the body. And that then is left for a long period of time, probably 15 minutes or so. Sometimes we only work on one side using this procedure. And I wonder if I can show a little bit in this and better anatomy, the kind of action it has on piriformis and the sciatic. So what I've done in some cases with hip joint disease, where there's not a lot of flexibility in the hip joint when I do the Faber test, is I'll do the pelvic procedure twice and the iliacus, and I won't be afraid to turn the patient back onto their front in order to do the deep sciatic. It's considered not done in Bowen, but when you're targeting, some of the regions of pain that the patient with hip joint disease is feeling, um, I think it's okay to be very aggressive with that sort of treatment because someone with that sort of pain may be experiencing iliotibial pain. They may be experiencing pain in the buttock. They may be experiencing pain in the groin as well. And these stronger treatments are are really valuable in circumstances like that. So that's my little announcement for this discussion. I'm going to stop sharing and see if anyone has a thought about that. Because I know that we're all a little bit afraid to do more and we tend to guard ourselves. But I'll give you this advice to measure how much you do. When the acute pain is very strong, well, they're already aggravated. They're already aggravated. So to aggravate them more is not going to be um, untenable for them. It's the low energy chronic pains that I think we need to measure ourselves and guard against doing too much and allow their body to build a little momentum in the treatment. And I'm feeling that we can almost use this sort of aggressive therapy, um, like a chiropractor would, you know, very aggressive. Sometimes the more disjointed the the problem is, the like more aggressive they are. And I may be wrong about that, but at the end of the day, it's not that aggressive in terms of physical therapy, but it is more aggressive than most Bowen therapists would be led to believe is wise or how they're taught. So I think it's an important idea that needs to be experimented with a lot because think about it. You've got these pockets of inflammation, and what do these moves do? They burst it. They literally burst it. And the patient may experience pain for a little bit more as they heal, but probably 2, 3 days later, they're going to be much freer in this problem with that sort of approach. And I think it's also something we might, want to consider in shoulder problems as well. However, as we all learn from experience, um, I think it's important to be given a bit of a green light sometimes to experiment. Yeah, that's my spiel. So I hope you enjoyed that idea. Bonita
Mhm.
smiling, Leslie smiling,
I have a
Rachel
question.
smiling. Yes,
When would it be? I've always treated both sides, regardless of whether or not the problem is on one side. I treat both sides.
you're talking
Um,
about the deep sciatic itself or generally with most
in
procedures?
general, in
Yeah.
general.
Mm.
But earlier, just a few minutes ago, you said it would be appropriate to only treat one side. And what
Oh,
would be
so that's with that particular procedure, the deep sciatic.
okay? And what would be the circumstance for that?
One-sided sciatica,
Okay,
one-sided piriformis pain,
okay,
one-sided buttock pain. If they had both sides of pain, then I wouldn't be afraid to do both sides.
yeah. So I've always treated both sides, regardless, just for symmetry.
Yeah, you
Interesting.
could. I mean, it wouldn't be wrong. It wouldn't be wrong. But remember, this is a very aggressive procedure, the deep sciatic. We're really sinking down, squeezing through the piriformis onto the sciatic nerve with a
Yeah.
big poke. And it almost, when you get it correct, it's almost like bursting a boil when it's needed. It really is.
Oh.
It's very, very significant move.
And almost always the client goes, "Oh,
Yes, they will. They will. That's good. I like to hear that. Yeah. So I think this could be a trio of procedures that you do try next time you have someone with one-sided hip pain. And in addition, the Faber test is useful for lateral extension, but it's the medial extension that really can reveal how bad the hip is that's when you have the patient bend their knees and you resist the knee going medially. And then that you ask if there's pain in the hip joint. That could be a very important measure of the degradation in the hip, how arthritic it is. Yeah. And I think that's really what I'm talking about, is a significant arthritis of the hip joint. Yeah.
I have also a question, Jonathan.
Yes.
It's also going a little bit to Leslie point, but I want to know by your experience, the sciatic points goes with the same side than the hip joint pain?
Yes, joint pain may be the cause of the sciatica, or vice versa. Yes, usually it would be the same side. Yeah.
Same side. And do you wait that your patient is telling you about this, that he has pain in the sciatic, or you do it automatically?
Oh, I would want to have them tell me the symptom. Yeah.
Okay. Thank you.
Yeah, I think that's also maybe another area of discussion at another time is, how do we get the right information in order to choose how to manage the case? And, I'm fortunate because I'm a homeopath and we know to dig for characteristics of a symptom. So perhaps getting as full a picture of how that symptom is what is important. So if someone tells me they're here for their hip, they mark on their little drawing of the body, the right hip, for example, and I'll ask them a lot of questions about it. When does it hurt? How do you have to manage yourself in order to govern the pain that you experience? What activities cause pain? How do they position themselves when sitting or lying? How does it affect their walking? Deep analysis of where the symptom is, how it affects them. Yeah, that will come out in the videos a little bit as well. Yeah. So those are available. Those 3 procedures are available on video to see them, and I think it's really exciting to be presenting these ideas. I can't say it would work for everyone, but it might be a similar group of aggressive treatments. And what got me thinking about this was we do a procedure called hamstring heavy. Hamstring heavy is almost 4 hamstring treatments in one session. And there's a part of that where as you're lowering their limb from a flex of the hip and a bend of the knee, you extend their leg and start to lower it. At a point that's comfortable for them, they can start pushing and resisting to almost lift their hip off the table. And that's almost like a tearing of the tension that's built up in the area. So that has been kind of a guidepost that has been very impacting for some stubborn cases where you want to really, get this to break free. And, sometimes Bowen can seem a little bit too slow in its effect. However, there'll be a lot of argument about this. There really would. I would not say I'm in the majority in this thinking. I'm probably, speaking just from my own personal experience and not afraid to be a little bit more aggressive. Doesn't mean harder. It just means more aggressive with the combination of treatment. So,
Jonathan, in that move, the hamstring heavy that you're talking about, you're talking like an isometric resistance, like where you're pushing and they're resisting it.
So I asked them to press downward with their leg from
And
their
you're
hip,
right.
and
Okay.
I'm resisting.
Got it.
Them pushing down. So that is really stretching the insertions of the hamstrings at the ischial tuberosity, the sit bone. Yeah. So have a look at that. It's an interesting procedure. Yeah, there's a video. Um, Actually, well, I'll see you next week. I'll show it to you. Good. I mean, actually, even another. I'll give you another example. TMJ. We've got two. The regular TMJ, where there's one space, and then there's an advanced TMJ where there are two spaces. Well, sometimes the jaw is so stiff and stuck that actually, and I got this from a chiropractic video I saw, where they literally hit the jaw aggressively to break its stuckness, you know. And so I've tried that a few times. It's not non unbowen like. I don't think so. It's just more forceful in terms of re-articulating the joint. You know, I think maybe I'm cavalier. I don't know, but um, I think sometimes we do need to be a bit more um, firm with our patients. Yeah. Yeah, you're all looking very happy with this.
Well, I can just share from my readings that both accounts of what Milton Albrecht had done,
Mm-hmm.
and also Mitchell Moser had done.
Yes.
They had also included heavier forces in
Yeah.
some of their procedures that they use in their particular Bowen styles. So it's not a foreign concept at all. There's some pretty, how shall I say, dramatic anecdotes about what Milton Albrecht had done at times
Yeah.
using force. And he was of the school of less is not more. He reportedly, I'm just reporting what I'd read,
Right.
it was that more is more, and as long as you give the body a chance to integrate it, meaning longer pauses than the 2 minute minimum, sometimes significantly longer. That was another slant he had on using force, and sometimes he would choose just one maneuver and used a significant amount of force. So it doesn't sound foreign to me. I must admit that I would definitely want to let the patient know that I'm going to do that.
Yeah.
But and then certainly not on the first session.
Yeah. No, you're absolutely right about that. And I'm sure, actually, it was interesting. We had a class last week in Livermore, California, and one of the students had taken training from one of Milton's students who became a teacher as well. And she was very strong, very, very strong. So that was quite interesting to see. Yeah, and you know, it's a like a game of telephone where you pass the message along. How strong should you be with Bowen? And I've had students from other teachers who are almost just too light, too light, not working the structure enough. The structures, especially fascia, muscle, tendon, not getting enough tension put into it to release in any manner. However, those same practitioners get great results as well. I think there's a wide scale of how to do Bowen, a wide scale, and you have to do what works for you as a practitioner to have the confidence to manage difficult cases. Because let's be honest, I think most Bowen practitioners see difficult cases. We don't really get straightforward cases because they would have been resolved with normal therapies.
Mm-hmm.
So you do have to, investigate hard and think very thoroughly how you're going to address these problems. Yeah.
I find, Jonathan, also that I have to read the client. And there's been a few clients that have come my way. They're used to going, they want deep tissue everything. And Bowen just isn't that. But in order to convince them that we're going to be able to produce some results, I have to be a lot more firm than I would with other clients. So to retain them so that they have this staying power to keep coming for the results.
Yeah, I mean, perhaps that's true. I mean, in a way, if I compare how someone who's been to a massage, for example, and I do a very straightforward Bowen therapy session on them, they'll have really such a relaxation
Yeah.
afterwards. But
Yeah.
it really proves itself in that sense. And then if they have a pathology, I'll make sure I'm going to address it in
Yeah.
early stage of treatment, probably the first visit, if it's appropriate. And mostly it is. I think also, starting a treatment, if they have a knee problem, a shoulder problem, you have lots of avenues into that problem. And I think you do have to start with the basic procedures: knee, shoulder, pelvis, sacrum. They cover a lot of bases. It's when we want to see faster resolutions that I think we have to be perhaps more aggressive in some instances. Yeah, I've got just flashed another thought. There's a procedure called patella release, which is a forceful release of the patella in an inferior direction. That's in the first manual, and it's not really covered so thoroughly in any. I don't even know if I have it as a video or in the classes, because that stuckness that a joint might have, perhaps post surgery, perhaps another injury of sorts. Um, we don't see them that often. We really don't. And when you do, and you see a response, it's a wonderful, wonderful feeling to have done that. And often those singular procedures are just one-offs. You only do them once, and then you're back to the basics. Yeah. Wonderful. Yeah. So, any other thoughts or comments? Well, it's interesting. I mean, Leslie, if I think of you and you have those clients that come for two purposes, and you add Bowen to the session.
Well, and I almost always have them then come back just for Bowen. They almost always come back
Right.
because the difference is extraordinary.
Yeah.
Mm-hmm.
Wonderful. And what about you, Bonita? You're so quiet.
I found something very interesting because, I learned the Bowen in like the late 90s. And then I didn't do Bowen for a long period of time. And I did massage therapy for 33 years. And I noticed, so I was very excited, since I'm not doing massage therapy anymore, that I remembered Bowen. And I thought that's something I could do that supports my body and I could still help people. And I'm finding that people are having their brains are having a really hard time, like, understanding how such little movements could do the things that are happening in their bodies when I do the sessions on them. It seems very confusing to them, and I think some of the people um still think they're going to go back and do Rolfing instead or whatever, even though they had this incredible experience happen with the Bowen technique. And so it's kind of confusing to me. The I don't know, the thought process, or why people would go do something else instead of the Bowen, even though they had an amazing experience with it.
I have to use some sort of hypnotism with these kind of clients. Yeah.
Well, I've had some pretty, nice experiences, and people have had some very surprising things happen. And But all of them are saying, wow, I can't, like they get up and they're so confused. They're like, how did I get that relaxed? I thought I was asleep, but I wasn't asleep. And it's just such a different experience for everyone. And that sense of well-being that they feel afterwards, it's pretty amazing.
Yeah. I mean, it's hard. I mean, you can only say so much.
I've had similar experience to Benita in terms of having people that have, and it kind of goes back to your original question, Jonathan, but kind of in a different way about doing too much. And it more is on the other side where people have done too many modalities and they come and they're like, well, I heard about this Bowen thing, let me try it. But then I had a client, this was several months ago, and they came, they had done massage, they had done, I think they had had physical therapy the same week, and they had been to the chiropractor the week before, something like that, some variation of that. And then they come see me and they're expecting either they're more expecting a result rather than the process, kind of understanding the process and thinking this is going to get fixed or whatever the issue is. And so that's happened. And then this person that came, they were like, well, I don't feel any difference. Like they've been through so many modalities that then they didn't feel it. But then they came back recently, before our class last week, and they had not had any other modalities that they told me that at that time, and they felt better after the Bowen. So it really, to me, was kind of a testament to that, this can work. But I think also it's a mindset too. I think people get it in their mind, okay, I'm going to try all these things. And so it just was a very interesting kind of observation of like, I felt like saying, see,
clarify the situation. So they came and had a very mediocre response to the response they had. In other words, they didn't think much of it.
Correct.
They returned because ultimately they had a good response.
Right.
Is that what you're saying?
I think so. Yes. Because I think they thought about it and processed it. Yeah.
That's wonderful. I mean, it's really wonderful. And, back to Bonita's scenario where people are sort of expecting something, not even knowing what they're really expecting, just more. It's hard to explain, but I think one of the things you can always tell a patient is it's not about what I do. It's about how you respond. And we need to see what your response is over the next few days. Let's just see.
And then there was a couple of those people also that were doing the same thing, like she was talking about. They did so many therapies, and I said, it could be overstimulating to have all of that stuff going on at the same time. How could you know what's doing what at any point? If you're doing that, because they have something going on, they want to get rid of it right now. So they do some of it, everything, like some things in the same day. And I didn't know they were doing that. I would have said, do this on a different day. This is not, it's too much,
True.
So,
I mean, true.
yeah.
However, there are going to be times when it could work. Sometimes it can work.
Yeah.
You mix things up. What I always want to do is explain that we need to know what does what, and having more time between therapies is best. And then come and see me when you've reached the limits of that therapy, when it's no longer moving and getting you better. You're better off saying no to a patient like that than trying to fit yourself into the crowd of other stimuli.
Yeah.
I think that's wisest. And it's hard to say no to patients. It is. But they respect you for it because you're really looking out for their best interest. And, you might just say, yes, we'll have Well, good night, Giuseppe. Thank you. Have a nice, good sleep and rest well. Okay,
Yeah,
bye.
as a therapist, I've offered, tell people I think this would be a better thing for you at this point, like a different type of therapy. So sometimes that's what's needed for a person, and that's good, share.
Yeah, I mean, yeah,
Share the
again, it's how they respond, not what you do. And therefore, if they're doing more than one therapy, how can anyone know how to manage any changes that come up? Because
Yes.
they might think it's the therapy they're doing and keep doing the same thing when it's actually not. Patients themselves need to be clear on what is effective and what's not. And I think
Yes.
most of us will experience that, yeah, within 24 hours to 48 hours maximum, the treatment will reveal whether it's helped or not. So exciting times, exciting times. So very happy this event is taking place. We've only done 40 minutes, but I think we covered a lot. And any other questions?
I don't know. Do you see my hands up, Jonathan?
Oh, I do. Yes, I just wasn't paying attention.
I mean, in education, so we raise our hands. Okay.
I've got there's an icon, and I didn't.
But my Bowen therapist, to the subject of knowing what does the job, she expressly told me to don't take, because she knew that I was coming to her for a specific problem, and that it was related to my job accident, and so I had also for my insurance to take some treatment. She really told me no treatment 5 days after Bowen. She gave me 5 days. So I had to do physio and chiro, but I was counting 5 days.
Yeah.
So is it a good idea to be so strict also?
Well, I think, I mean, if maybe that's more okay. So we're told in the learning of Bowen therapy that the effect of the treatment is about 5 to 10 days. And we're told to come back, to have our patients come back 5 to 10 days. So a week is a kind of easy scheduling timeline. But I've learned that sometimes patients need to come the next day. That's the type of pathology. So it depends on the pathology you have. So to say 5 days without knowing anything, or to judge 5 days without knowing anything, I can't say. But that I think is not unreasonable, to separate the time. Do you think it was helpful to wait 5 days?
It was more separating the treatment to know what is working, Mm-hmm. For me, she was really honest. She told me it might work, it might work, or it might not work. Give minimum 3 sessions for the chances that it's working, and that's true. And I say, okay, I accept all that. And first session, no result. Second session, no changement, no result. Third session, after a few days after the third one, wow, hallelujah. Because, I've been really to a lot of different treatment to find a solution for my problem. That's the reason I'm coming to Bowen now.
Yeah.
It looks great.
Thumbs up. I saw that. I didn't see the what is it? It's a hand. Yeah, a hand. I didn't see it. I'm new. Zoom is too complicated. There's so many little details. I find it difficult. Anyway, that's really wonderful, Valerie. And I think it says a lot for the experience of the practitioner you went to, that they knew your type of problem. Yes, it might work, it might not. And that was a very honest statement. Really good, really good. So 5 days sounds really appropriate in your situation.
Yeah.
I mean, really, in a way, if you say to a person, I need 3 treatments, it's basically 2 weeks. If you see them, let's say on the 5th, the 12th, and the 19th, that's only 2 weeks. So there's not a lot of time for anyone to sacrifice other therapies, especially if they're going to them and not getting great results. So that's another sort of way to look at it. Yeah. All right. So anything else you want to pipe up? Pipe up now. I'm going to sign off early. 45 minutes. That's not bad. And that way it's not so long for the ones who watch video afterwards. And we're not just, you know. Okay, well, thank you for joining. And this time is working out for you guys? Yes, I think.
Yeah.
Okay, good. A lot of
Good.
people complained, well, I can't join, I'm in bed, I'm working, depends. But I can't do, 24 hours. It's not going to make everyone happy.
It's late for me, but it's fine. I'm up anyway, so it's
Right.
okay.
Right.
You're never going to make everybody happy.
That's right.
That's probably good advice. Yeah. So thank you. And
Thank you,
I'll send a
Jonathan.
notice about the
Thank you.
recording
Thank you so
if
much.
you want to see it again, or I'll send the next meeting notice. So thanks for joining.
Okay.
Thank you.
Take
Bye-bye.
care. Bye.
Bye-bye. Aloha.
Aloha.